Hello, everyone. Welcome once again to the Multiple Myeloma Patient Physician Partners Program Series. We are at episode 2 out of 3 already. My name is Tiffany Drummond. I'm an advocate who has worked in cancer research for 20 years, but more importantly, I became a care partner and advocate when my mom was diagnosed with endometrial cancer in 2014. Her journey led me on a quest to find out as much information as I could to help with her care, and it wasn't easy to find. And that's why I am honored to join the patient story in putting on programs like the one today to help people navigate life after diagnosis. This program is hosted by The Patient Story, where we aim to help people navigate life before, at, and after diagnosis. Now, how do we do this? Through empowering patient stories and educational discussions just like this one, where we focus on how patients and caregivers and their partners can best communicate with their doctors as they go from diagnosis through treatment with myeloma. We want to thank the Leukemia and Lymphoma Society for its partnership in this program. The LLS offers incredible free resources like their information specialist to help you communicate with members of your healthcare team and provide information about treatment options. Now, before we get to our speakers, we want to thank our sponsor, Sanofi, for its support, which helps us host more of these free programs to our audience. The Patient Story retains full editorial control over all content as always. I hope you find this information helpful in the program today. Please keep in mind that this program is not a substitute for medical advice. We know that there is a lot you want to know more about and that you want to discuss or at least tune into. So please let us know what those are, along with what we could do better. A survey will pop up after the program ends, so make sure you stick around. Okay. Now, let's get to the good stuff. I'll be leading today's conversation, so sit back, relax, and get ready to be engaged and empowered. Thank you, everyone, for joining the Patient Story for episode 2 of our Patient Physician Partners Program series. And this is, again, going to be about multiple myeloma. And I am Tiffany, who leads the community programming and partnerships. And today I have 2 special guests that I cannot wait to introduce to you and learn more about that patient-physician partnership. So my 2 guests today are Dr. Caitlin Costello, who joins us from UC San Diego Health, where she serves as an associate professor of medicine. And she's also a hematologist oncologist, where she specializes in a variety of blood cancers, including myeloma, lymphoma, and leukemia. Thank you so much, Dr. Costello, for being here today. How are you?
Hi, Tiffany. I'm great. Thank you so much for inviting me to be here with you 2 fabulous women to talk today.
Thank you so much. And which brings me to the woman of the hour, our patient, Michelle, who is a multiple myeloma fighter and a survivor. So Michelle, how are you doing today?
I'm doing well, thanks. And thank you so much for having me today.
Perfect. So I'm actually going to start with you. Let's just kind of take it all the way back to that initial diagnosis and what that experience was like for you.
Okay, I was diagnosed in 2016 at the age of 35. I had a 5-year-old and a 1-year-old at the time. The year prior, kind of leading up to it, I had back pain off and on again. And then I ended up having some other symptoms that kind of led me to go to the doctor more. I was starting to lose weight, which they kind of were saying that was from breastfeeding. And the back pain, they were saying I just had a baby. And that why my muscles weren't strong. But then I ended up having some severe stomach pains, which kind of I was at times wanting to drive myself to the ER. And I ended up having some like skin issues where I was having these itchy scabs all over my body. So I ended up going to the dermatologist and to my general physician saying something is really wrong with me and we need to find out what it is. So they both started digging. And my general physician started ordering a bunch of lab work, and which eventually kind of led to having the diagnosis of multiple myeloma.
So this actually brings me to another question, kind of a twofold question. So when you were first getting this feedback from your, physicians that you were seeing, and you knew in your gut like something isn't right, what did it take for you to really say, you know what, I have to advocate for myself, like something is wrong, like we need to figure that out? And then the second part of that is going to be when you were referred to a specialist or an oncologist, hematologist, what was your first initial experience like? Or if it was with Dr. Costello, I know it was already great. So that was my next.
Yeah. So kind of my husband travels a lot for work, so I was at home with my 1-year-old and 5-year-old, and I was having these stomach pains and didn't know what to do. And I literally was almost driving myself to the ER one day, and I was just like, okay, let me just take a breath. I was driving already. It kind of pulled over, the pain stopped, and I think I ended up calling my doctor that day and saying, you need to see me tomorrow. And I'd already been seeing the dermatologist about the kind of scabs that I had all over my body. And she was looking into things. I didn't know if any of it was related or not. And then finally, when I got the diagnosis, my husband was home. He came home, picked up my 1-year-old. We all drove to the his doctor's office. My husband stayed down with our 1-year-old so I could actually listen to what he was saying. And he said, you have multiple myeloma. And at the time I was like, okay, is that cancer? Because obviously he called that day and said, you need to come in right now. So he said, yes, kind of explained what it was and sent me to a oncologist, hematologist in their group, which was not at UCSD at the time. So they got me in actually that day, and the oncologist, hematologist there did a bone marrow biopsy. And when we got home, we just started making calls, and that was kind of what led us to Dr. Costello. I actually called my boy's pediatrician, who I absolutely loved and valued his opinion. And I said, you're a doctor in the area. Where do I go? Who's the best? And
Right.
and we reached out to kind of several other people, and they all led us to Dr. Caitlin Costello. So we gave her a call, and she was able to fit me in right away, and it's never looked back.
Right? The beginnings of a great relationship. So, Dr. Costello, this brings me to you because Michelle actually said something that I find part of in my former life. I was regulatory with hematology oncology. So I tend to find that a lot of times, especially with blood cancer, that those symptoms, you don't really know what they are, right? And so if you can kind of just talk to our audience, because even though I talk to hundreds of doctors, they all explain myeloma differently. So how do you explain myeloma to your patients?
You're so right on, Tiffany, because I think so many people, when they hear of cancer and think of cancer, they think of a lump, right? Like a breast cancer, if they felt something, or, there's some symptom oftentimes associated with a quote tumor, right? But when you're talking about blood cancers, there's no usual kind of tumor associated with it that can sometimes be picked up on routine screening tests, which there really aren't any for myeloma. So unlike kind of more quote unquote typical cancers where we're so used to having kind of public health initiatives for mammograms and colonoscopies, multiple myeloma, while still is the third most common blood cancer, still doesn't come anywhere near in terms of the, number wise of how many patients are affected in the United States each year. And for that reason, for better or for worse, I don't think we have kind of good epidemiologic advances to say that every single person should have a screening blood test looking for this, and in fact there's ongoing interest of that now, kind of screening wide groups of populations. They're literally screening the entire country of Iceland for all patients over the age of 40 and say, let's just do blood tests and see if we can figure out how many patients have what look like the beginnings of multiple myeloma, and if they're not myeloma at that point, kind of understand what it makes, does it make sense to screen patients? So we'll be excited to hear from some of that data to understand that. But for the most part, that means that most patients are diagnosed with multiple myeloma when they develop a symptom of some sort. And so asking, the question that you've asked in terms of how do I explain multiple myeloma to patients, Michelle, you said it so right. Many people have not heard of myeloma. So your doctor says you have multiple myeloma, and then they're like, and what does that mean? So I always try when I'm describing multiple myeloma to say what we have identified as a form of a blood cancer called multiple myeloma based on your blood tests and your bone marrow tests. And a lot of my consultations with patients is to really explain that diagnosis, because what a wonderful problem we have with myeloma, that this has really turned into a chronic illness, right? So patients are going to live with this for the rest of their life. So there is no greater importance of understanding and knowledge so that patients know what it is that we're talking about, knows how to follow their own blood tests and understand the successes of therapy, or perhaps this early signs of kind of failures of therapy, if you will. But also be able to do exactly what Michelle did, was advocate for herself, right? To say something's wrong. I noticed this. I need this. I need help. I need you. I need you, So I think there's so much to say of the educated patient, and that does not mean Dr. Google. I think there are very good patient advocacy groups, the patient story, things like this, where patients can get really great information to help them understand their disease and kind of their own personalized journey with it. So when I explain myeloma, I think the basics of it are explaining that multiple myeloma is a form of a blood cancer, that it comes from a cell called a plasma cell that is part of your immune system. Your plasma cell is designed to kind of produce the weapons we need to protect the machine, right? And I describe the bone marrow as like the armed forces. We got an army and a navy and an air force and, all these different branches that have different weapons that are designed to protect you. And one branch went rogue. One plasma cell went rogue and started producing all these extra kind of bad guy, weapons that really don't work well, and they cannot protect the machine, and in fact cause damage. And when we're talking about kind of the different ways they talk about damage, bones are the most common way that myeloma can affect a person's body. And therefore, that is sometimes some of the most common way that patients are eventually diagnosed with myeloma, because they come seeking help for pain. And, back pain, just like Michelle described, is one of the most common ones. We think that the bones kind of in the middle of our body is more often affected than kind of other bones elsewhere. And so the story is classic of, I had back pain, my doctor did x-rays, they didn't really see anything, or they referred me to physical therapy and it just got worse. And so pushing the envelope after kind of the usual things, because everyone's allowed to hurt, right? But a pain that doesn't go away and came on for no good reason and it's persistent really does need to be evaluated. So, Michelle did all the right things, because she had typical, now we can say kind of typical symptoms with pain, some atypical symptoms with the skin and the belly discomfort, but asked all the right questions to get her to the right people who could help.
See, this brings me to my next question. First comment, that I love that you talk about patient education. So I have a two-part question for you as well. How receptive are your patients to wanting to learn that? Because I do believe that part of patient education are learning those medical terms you probably weren't familiar with before. So how receptive are they to that? And then my next one was going to be, what are, if you had to name three, I'm pretty sure there are more, the top three common questions you get after someone is diagnosed with myeloma?
Absolutely. So let me answer that question first. The top three questions are, how did I get this? What can I do to make it go away? And is it genetic? I think those are the main three things, because everyone wants to feel empowered that they can make some change, some lifestyle change, for example, that is going to make this thing better, or, help rationalize this to some degree to say, X caused Y, and much like smoking causes lung cancer, it would be fair if there was some culprit, but it's unfair because there is no culprit. We think this is a random thing that happened for no good reason, by no fault of anybody's, that kind of nature just changed the makeup of, your bone marrow and the part of your immune system.
Right, absolutely. So, Michelle, I want to ask you this. It's actually for both of you, but I'll start with you, Michelle. So when you first met with Dr. Costello and she's explaining your treatment options to you, when I ask about your experience, I'm really asking, how involved were you in that decision-making process, right? Was it more like, let's have a conversation about your options, or is it like, kind of, this is where you really need to go? And how receptive were you to that information? And what did that experience look like?
I think Dr. Costello just presented me with, this is kind of what our standard of care is for when people are diagnosed with multiple myeloma at the time. It's very receptive. I did seek a second opinion at the time. We kind of reached out to another multiple myeloma specialist kind of in the vicinity and went and saw her as well. And she confirmed the same thing. So we just went ahead and went with what everyone was recommending.
And so, Dr. Costello, for you, when you are approaching your patients about their treatment options, what is your thoughts? Because now there's this buzzword, which is shared decision making. And so how do you approach this with your patients when it's like, this is kind of the standard, this is kind of where, based on your clinical determination where we need to go. But what factors do you consider in that to help them come to that shared decision making process with you?
So, I realized I didn't answer the first part of your last question, which plays into this nicely, which is that every person is different. People
Mm.
process information differently. People hear information differently. And some people want to know more and some people don't want to know more. So I think an important part of any conversation is to level set and say, what do you want to get out of this conversation, right? What is it that you want to know? And more often than not, the patient has something in mind that the family members there have something different in mind. So I think it's important to kind of gauge the group to some degree to say, what is it that you're hoping to get out of today so that I can make sure I'm not overstepping some of those boundaries? Because some people want data and some people don't, so I think that is the first most important thing. And so once we are then able to kind of establish how much will be shared, I think my job is to kind of give the information as Michelle said, what is the standard of care? What is the typical approach? Once we've kind of laid that groundwork, then we can kind of say, all right, but based on you and the details of your health, your caregiver support, your biology of your disease, there are very specific details that can make my treatment recommendations slightly nuanced for any individual person. Mm-hmm. And I love that Michelle went and got a second opinion. I have no ego. I think when you are diagnosed with something like this that is so absolutely life-changing, you need to feel very confident in what your next approach is going to be. And I think the more people thinking about you, the better. And I mean, I like many myeloma specialists, this is what we do. We do all day, day in and day out. But it's nice to have a fresh set of eyes also. So, just to make sure that there's nothing that's missed, that there's, yesterday's information may have been different from a month ago's research that has been set out. So I think, the approach is standard, but the shared decision-making is where things may be slightly different because I can make all of my recommendations that say, this is what's standard. These are the slight modifications I would make for you. And sometimes the patients will take that information and kind of say, I'll get back to you. Some people will say, let's do this, whatever you say, doc. Some people will say, no, and I'm not in their body. I'm not making decisions for them. I think my job is to help them be as informed as possible so that they can make the best decision for themselves. I may not agree with their decision, but that's not my job, right? My job is to help them come to the best decision that's for them.
I am so glad we're having this program because you literally said everything that I wanted to hear personally, especially when it comes to a second opinion, right? Because I know a lot of patients out there, especially if they really do like their physician, at the first meeting, they don't want, because they have this internal emotional feeling that they're like turning their back on or, on their physician. And so for you to say, no, I encourage you if that's what you want to do. So thank you so much for saying that. And so I think, Michelle, you said 2016, right? Is that when you were initially diagnosed? So where are you in your treatment journey now? And what does that look like for you? Because there's some years out now and you look beautiful, my dear. So tell me.
Thank you. So I initially did my kind of 4 months of the initial regimen kind of treatment and then went into a stem cell transplant, the autologous stem cell transplant. And unfortunately, mine was not successful. And the myeloma came back within the 100-day mark. So we kind of considered that a failed attempt and kind of regrouped, went back on kind of one treatment for the summer and then kind of regrouped again and did a more aggressive approach. And the MRD testing at the beginning of this year showed that the myeloma was slightly coming back. And to be honest, it was kind of affecting my quality of life, and was just ready for something different. So we regrouped again. The doctors agreed that I could take the summer off of treatment, and I did a repeat bone marrow biopsy so I would have some initial data to compare against when I started my new treatment plan.
I'm sorry, did the pandemic affect your treatment at all, just when everybody was kind of stuck indoors and things like that? Because I know that cancer did not stop for the pandemic.
No,
So,
cancer does not stop the pandemic. And it gave me a lot of anxiety, but I had to persist through. So even when the initial pandemic and everything closed down, we
mhm,
were on the phone going, "Am I coming in?" And she said, "Yes." So I went in, I think it was at the time every other week into the infusion center during
mhm.
all through the pandemic.
So
And
my question for you, and I'll follow up with Dr. Costello, is how, because I know that especially when it comes to cancer, you have more than one healthcare provider. Your healthcare team is very vast, right?
yeah.
So is that specific to UC San Diego, or do you have local providers that you also go to? And how do you coordinate all of that? Because I know it's a lot of information that you're always receiving. And how do you coordinate that for yourself and share that with someone like Dr. Costello or your other local providers when needed?
So yeah, so currently I don't live in San Diego anymore and have a local oncologist, hematologist here up in Sacramento where I live. And so I've always valued a second opinion. And like Dr. Costello, initially she said, I have no ego. And like you all said, I feel that this is kind of my disease and my choice of what to make. So I've always sought um, second opinions, especially when I'm making big decisions about changing treatment plans and what to do next. So I've kind of I coordinate now. Thankfully, the multiple myeloma world is pretty small and they all know each other. And I've always been able to kind of discuss me with each other. Recently now, even if I don't agree with one treatment plan, I am able to kind of seek a different opinion. And they both have been very kind and taking into account my quality of life and what I would like. And I think information is kind of the best. So I seek both their opinions. I kind of weigh out what I want to do and how that's going to affect my life, especially with raising two active boys, what I can handle as far as, raising them and
Right. Yeah.
having a great quality of life with them, and then kind of make my choice of how I want to proceed
Yes.
and based on their recommendations.
Yeah. So, Dr. Costello, my question for you is for someone like Michelle who doesn't live in your local area, how do you approach seeing patients from afar? Is that something that you do? And also, I just had this conversation recently about large academic centers where you're more specialized and how you share information with local providers who may not have that same knowledge that you would have. Do you encourage that to say, let me know what your local provider is saying, or how does that work for you?
Um, Great question. And I don't feel like Michelle gives herself enough credit. So, from everything that she just said, while raising two young children, while in the midst of a pandemic, while doing, I told her to jump and she said, how high? It really is such a commitment to her health and her boys and her family. And I think she was able to get her care at UCSD, where we have kind of myeloma dedicated physicians. But you're right that most of myeloma patients are taken care of in the community, if you will, where you are seeing an oncologist who is maybe a general oncologist who is seeing you right after they saw someone with breast cancer and right before they see someone with lung cancer, and they often are good at myeloma, but it's hard to be, a jack of all trades also. And that's where I think the importance of a myeloma specialist comes in here, because I don't know how they do what they do, right? Seeing so many different cancers, I have a hard time keeping track of one, let alone all of them myself. So I think this is where I like to say myeloma is a team sport. Right? Your team includes the patient, the myeloma specialist, the general oncologist, your nurse navigator, your nurse, your social worker. It really is a whole team of people who are trying to come together to kind of, hold hands with Michelle and our patients to kind of get them, get through this whole process. So what a lot of that can be, especially in California, I can't speak for, other places, but a little insurance driven, because some insurers will require you to stay with your community oncologist. And if that's the case, The patients do get referred in for their stem cell transplant or CAR T or whatever treatment we have to offer at the academic center that perhaps the local oncologist cannot offer. And that allows us to kind of maintain some of that relationship with our patients as well, because I have a list of text, numbers, phone numbers and text messages of all my local community oncologists down here, because we are constantly talking about our patients kind of behind the scenes to say, hey, my patient just relapsed. What do you think we should do? And I say, hey, can you bring them over here and let me talk to them about this and that? And so I think the importance of the connection between the community oncologist and the academic myeloma specialists is, can't be underlined enough, because we have different tools at our disposal. The way myeloma is right now is that it's complicated. There are so many drugs, which is a wonderful problem, but that means that it can be complicated to understand, well, which drug do I use now? Which order do I do it in? Should I choose this first or that first? And so that kind of connection between the oncologist in the community and the myeloma specialist is absolutely paramount to kind of navigate this whole thing.
I wish I could put emojis in here, but I know I can't for my program, because I'm so excited about everything you're saying right now, because you're spot on. And Michelle, you had mentioned quality of life, which I know, especially I used to be a caregiver, so I understand how important quality of life is to everything that you're doing. And so when you say you took some time off and that you were able to do that, how important was your quality of life in driving your treatment decisions? And then Dr. Costello, how important are your patients' quality of life in you making the decision as well to say, this is what we're going to go with? So I'll let you start, Michelle.
One, I want to be around for my children. So that's my top one priority. And however I'm going to get there, I will get there. I will cross that finish line no matter what it takes. So that's kind of always my main goal, is that one, I want to be well and healthy and to see my boys' future. But I want to do that right with a great quality of life and be able to see them. So when it starts, I start not feeling well after treatments, and, I'm really just kind of dragging. And I was really starting, I feel like, to even have it was kind of almost, I forget the term, but I was making myself nauseous before even getting to the treatment. It was like a psychosomatic thing. It was like, I know I'm going to get nauseous, so I'm already nauseous. And I was like, this is not good. I need to kind of start switching things. So that is important to me. I'm very fortunate enough where I have a lot of flexibility in my time. So I'm able to make doctor's appointments, and I'm able to do my treatments during the day when my boys are at school. So it really tries to lead the best life, that it doesn't affect my children, and I'm not in the infusion center when they're home going to bed. And that's very fortunate, and I'm very blessed to have that opportunity.
I'm just waiting for the two little ones to go behind the screen. I'm just waiting for that. So Dr. Costello, so in terms of quality of life, and you can let me know about this too, only because I'm interested in the research, is there increasing data that actually looks at quality of life when it comes to myeloma, and that treatment option that kind of correlates with that?
Absolutely. I think, quality of life is, I don't even know how to emphasize it enough, right? I mean, I think people kind of think of it and say, is it quantity of life? Is it quality of life? Is it both? And, I ask that to some degree to say, what are your goals here? Because people's goals are different. And, it's realistic, though, however, to say that some of our treatments are not really that great quality. They're inconvenient. They take up a lot of time, even though they work. So it's a conversation to say, well, what are the deal breakers for you? Because there are some patients that say, I don't want to be in an infusion center. I only want to take a pill, and I'll take the pills even if it means it's not as good or effective of a drug, because that's what's meaningful to me. So I think that conversation is that same shared conversation to say, what are your goals? And as far as the research goes, fortunately, a lot of different studies that are out there now that are looking at different new drugs or new drug combinations are including what we call patient-related outcomes, where people may hate it, but there's a lot of surveys that happen in the midst of clinical trials to say, how's today? How's today? How's your body image? How do you feel like this? Are you content with this treatment? How do you perceive the side effects of treatment? How much time is this taken out of your day to do this? So I think there's more and more interest of, expanding upon what we've always relied on for clinical trials to evaluate the safety of drugs and the efficacy of drugs, but also to incorporate how these drugs can change people's lives, both positively and negative, to help guide your doctors to make decisions to say, I know they work, I know they're safe, but I also know that many patients said this about it, and help patients understand if that's that deal breaker.
So you brought up one of my favorite terms, which is clinical trials, one of my favorite topics. So I have this question. I'm not sure if you were on a clinical trial, Michelle, but Dr. Costello, I do want to ask, because oftentimes I'll hear patients say, they don't want to go on a clinical trial because they think that's the last resort. Instead of, maybe this is like for, newly diagnosed as well. And so how do you approach the clinical trial conversation with your patients?
I think to first, most importantly, dispel this myth that placebos still exist, right? Because some people, still have it embedded in their mind to say, well, I don't want the sugar pill or the placebo. And what I always say is that is not ethical. We do
Right.
not do that anymore. Clinical trials are designed to give you what we consider the best available right now, and or compare it to something that we think is as good or potentially better. So I describe it to patients to say, you are potentially getting the best of both worlds, no matter what kind of you get assigned to as clinical trials. But I think, number two part of clinical trials is to help patients understand that there's various phases of clinical trials, some of which are randomized, yes, where we don't get to say, I want this treatment or I want that treatment. Some of it is to say, we don't get a choice, we'll get assigned to one or the other, but both are great options for you. Or there's an earlier phase trial, which is, evaluating, like I mentioned, the safety or efficacy of these treatments, and every patient will get the exact same treatment. Mm-hmm. There's a thought that, participating in a clinical trial is purely altruism. And yeah, to some degree, yes, you are helping the future of myeloma therapies, but you're getting the benefit yourself from it. And so clinical trials are not always designed to be just testing the next thing when patient has no other options. It's improving all the steps of treatment that we know exist now, because we can always do better. So clinical trials are taking treatments that we use kind of as a standard of care now. When someone walks in with newly diagnosed and says, this is what we have as a standard of care, but by the way, we know this works. There's this clinical trial that's evaluating this that has shown already to be very promising, that we think could be at least as good. So I feel like a lot of clinical trials is dispelling myths, when the conversations come up, and helping people recognize that it's not just for others. There's really great benefits that can be reaped by participating in trials to get access to cutting edge therapies that I otherwise cannot just write a prescription for.
Right. So Michelle, my question for you is, how knowledgeable were you before about clinical trials? And I ask this to any patient that I speak with. Just in general, did you know about clinical trials and what they were and things like that?
I did know about clinical trials. I actually have a degree in public health. So I'm a research girl, and I did know about them. I unfortunately have not participated in any, just it hasn't worked out that way.
That's absolutely fine. I didn't know that. So we're all into research here. I love it. So we're going to be actually wrapping up again. I want to thank you all so much for your time. And so, Michelle, what I really want to ask you is a key takeaway. What would you give a patient that is newly diagnosed right now, a key takeaway of something? Because it seems like, honestly, you did everything right. So I do want to commend you for that, and please give yourself credit for that. But if there's something that you could tell someone, like, if I had known this, right? Is there anything that you think, I wish I had known that, and then I maybe would have taken another direction to get to where I am now?
I don't know if I would take another direction, but I always say you're your best advocate. So do your research, advocate for yourself, seek other opinions, and kind of make the best informed decision for yourself.
Absolutely. And Dr. Costello, my last question for you. This is going to be advice to the providers out there. What is your advice? How do you help someone, a provider, be an active participant and proponent of, informed decision-making and that shared decision-making, especially for maybe junior providers out there who are kind of coming into this fold? I think that's something that I personally want to see for myself as well. But I think that you're a testament of that. And what advice would you give providers out there to be that person that has a relationship like you and Michelle has?
Thank goodness that that kind of paternalistic approach to medicine is a thing of the past, right? And while there may still be a bit of it out there, as you will do as I say, I think there has been such, maybe for better or for worse, but let's say for better, an important message about, to some degree, customer service with medicine, right? It really is a evolved into a little bit of a service industry, not as much as going to buy something at a shop, right? Because I think you have to understand that this is a relationship that is give and take to some degree, right? To say you deserve to hear all, the patient deserves to hear all the information. It is the physician's role and job to give all that information. And, there's been such an important emphasis on just compassion and communication, I think compassionate communication. If the physician could put themselves in the seat of the 35-year-old newly diagnosed mom walking into cancer center on the front door, I think we can all kind of step out of our bodies, step away from our egos, and understand that there is more here that can be really developed in terms of kind of developing that relationship and the importance of that communication. And really just kind of understand that, we have much to offer, but our patients have so much to offer us as well.
Thank you so much. And I want to thank Michelle and Dr. Costello for such an engaging and empowering conversation for our patient physician partner program for myeloma. And thank you again so much. I know that I learned a lot about both of you personally and professionally. And I think what you've had to say today is really going to resonate with a lot of our audience out there. So thank you so much for being here.
Thank you,
you.
Tiffany. Thank you, Michelle.
Thank you, Michelle and Dr. Costello, for a great discussion today. Dr. Costello is truly a testament to what makes a great physician partner. Seeing and hearing her and Michelle interact was refreshing, since we know the patient-physician conversation isn't always lighthearted when it comes to cancer care. Again, thank you so much. To wrap up this discussion, I want you to leave with the takeaway that it is important to be empowered so that you and your caregivers can make informed decisions about your care. A reminder, we want to hear from you. A survey will pop up when this program closes, so don't go anywhere. Thanks again to our sponsor, Sanofi, for its support of our independent patient program, and to our partner, LLS. Check out the LLS website and make sure to check out their Information Resource Center, which provides free one-to-one support. Until next time, I'm Tiffany Drummond signing off, and on behalf of the Patient Story, thank you for watching.